because I thought, instead of having everyone giving us like their talks about ECMO and how they do it, I think we could do it like as a round table, a virtual round table. So I have a bunch of questions for you today. And if any one of the participants have questions, you can just type it in the Q and answers, and then we will read them too. So my first question is like, how do you decide that you're going to put a patient on ECMO? Do you only use the EOLIA criteria? Anything else you look at? I leave it open for everyone.
I could start. We'll tip for ARDS. We'll typically, go by EOLIA criteria as our initial consideration. Really considering someone's severity of hypoxemia. The PDAF ratio is less than 80, despite optimized ventilator settings or adjunctive measures like prone positioning where appropriate, or if they have a hypercapnic respiratory acidosis with a pH less than 725 and a CO2 greater than 60, as was used in EOLIA. For their criteria. We also will look at someone's trajectory. So for example, if somebody maybe was just intubated, earlier that day, they've been quickly maxed, and maybe they're, very, right around like that entry criteria, but we see a quick downtrend or a quick decline, we'll sort of anticipate and really try to be prepared, for cannulation in those patients. And certainly with specific patient groups, there are other issues to consider. For example, in pregnant patients, if there's any signs of fetal instability or whatnot, and obviously for non-ARDS indications such as asthma and whatnot, we have different criteria for selection.
Eddie,
Eddie?
Eddie, okay, well, yeah, so yes, in France too, we stick with the EOLIA criteria. My main nuance will be for patients with a PF ratio between 80 to 100. As Cara said, I think the trajectory of the patient is quite important to consider also for how long the patient has been ventilated. And if we see that progressively the response to prone positioning is decreasing and the respiratory mechanics is also getting worse, mainly the driving pressure. So in that case, it could be some possibility to go a little bit further than the strict EOLIA criteria by considering the respiratory mechanics and maybe considering a PF ratio. Even if the PF ratio is 80, 90, or 100, we may still consider putting the patient on proning, especially on ECMO, especially if the patient is not responding anymore to prone.
Eddie, do you have any different criteria or things you consider?
No, I don't think I have anything else to add. I think agree with everything that Cara and Matthew said, that it would say we use very similar, if not exact, criteria for ARDS here, but just to raise, as Cara mentioned, that there's a whole host of other kinds of patients like bridge lung transplant, asthma, COPD, maybe post-surgical patients who've had a complex procedure or something like that, where we might have special considerations. So these obviously haven't been tested in clinical trials, so there's no specific inclusion criteria to follow there, but certainly for ARDS, if that's the main main indication that you're asking about, then yes, we use the same criteria that Cara and Matthew mentioned.
Do you always prone your patients when you're like thinking about considering ECMO for either hypoxemia or hypercapnic respiratory failure? Is always a step you go through?
Yeah, at least in France, yes, we love prone positioning. It doesn't cost anything. It can be done everywhere without any money, and that's why almost all of our patients have been prone at least once before being considered as a candidate for ECMO, except some rare situation. I will just add one point considering your previous question. I think when you have barotrauma or fistula, bronchopleural fistula, it could be also one very rare indication when the EOLIA criteria are probably too strict, and maybe additional point to go for an ECMO maybe early on rather than waiting for the acute deterioration like we can see in the EOLIA criteria.
Great. And so following up these questions, do you think like postoperative patients will have contraindications for proning, let's say a post-double lung transplant surgery, intrathoracic surgery? Would
So
you still prone the patient?
it's a case-by-case discussion with an agreement with the surgeon, but most of the time we have an agreement of the surgeon, and for thoracic surgery, even for thoracic surgery, we still do it. But again, it should be a team decision. But I think it's doable most of the time.
There's a question that says, is there any specific criteria for early ECMO? Or I don't know if you, there are some patients besides the one that we have discussed that you will jump into cannulation before deterioration.
And I think the evidence that we have really shows that there's evidence and good evidence for early appropriate ECMO. So like not to jump the gun or not to be, too eager in someone who has, let's say, moderate ARDS without any other sort of, comorbidity or something that might prompt us to do ECMO in less severe patients, especially those really firmly within that moderate range. But I think once somebody does meet criteria or, is close to meeting that criteria in the patients that we've sort of all mentioned, it doesn't make sense to delay the initiation of ECMO further. If someone's failed prone positioning and their PDEF ratio is less than 80, or if they meet criteria, we should act as soon as we safely can to get that patient on the support that they need.
And this is a very personal question because it was a discussion with one of our group of residents this time. Is like, how do you know if someone is responding to prone position? Like, what will you consider a successful proning trial? And I think Matt things to say about it.
So clearly, PF ratio is probably not the best surrogate of being a responder, but even if it's currently used, but probably having a decrease of the PCO2 is maybe more valuable to identify who is a responder. But the question is still open. I mean, we all have various definition of who is a good responder, which degree of improvement should we expect with this procedure. I think it's still an open question, but I will say PCO2 first, PCO2 decrease, and maybe PF ratio lower at the end, but PF ratio is not the only one.
Yeah, I agree. I think, to not make it seem not to be facetious, but I think if the patient doesn't die on proning, it's a success. The ProSiva trial showed that on average, patients got about 4.5 proning sessions or 4.5 days of proning. And every day, as Mathieu said, the PF ratio would increase over the course of proning. There's a time-dependent process. And then you'd start and prone the patient, and again, the PF would drop, but every day the new baseline would be slightly higher and the PF would improve. And again, in ProSiva, at least PF was a criteria for the stopping of proning. So they followed PF. But in subsequent analyses, one by Rich Calais, showed that actually it didn't matter. Even patients who didn't have a change in PF ratio in ProSiva, they derived a mortality benefit. And we've had a number of other studies, including one that we performed in Toronto with our colleagues in Spain using the Ventila data, showing that even respiratory mechanics don't seem to be a very good predictor. But to Mathieu's point, of the things that we looked at, like compliance, driving pressure, and these sorts of things, ventilatory ratio seem to predict or have an association with mortality. So changing PCO2, as Mathieu said, probably might be a good surrogate. But again, I think agreed, it's an open question. It seems that there's no clear parameter that isn't associated from ProSiva with mortality benefit. So even if nothing changes, it seems that proning again is a lung protective procedure and it's associated with the benefit. So again, it goes back to the original question of the trajectory, how the patient is doing, if other things are not improving, and you might have a compelling reason to switch or initiate ECMO, but it's hard to say that there's something to monitor specifically to say the proning is successful or unsuccessful.
So when you get referrals, what do you get most commonly? Like early referrals, meaning they have not prone the patient, or sometimes you feel it's like too late, the patient has been vented for a couple of weeks. It's like for these people that need to call us, like what are the things that you recommend that they should have tried before they call us? And what information should they really have to call like for an ARDS, a specific ECMO center?
So I can start. The main information that we need to get to make the proper decision to identify who might likely benefit of ECMO. It's mainly age, the immunocompromised status of the patient, for how long the patient is ventilated, what is the cardiac function, especially the right ventricular function, what are the respiratory mechanics, have you tried prone positioning, and are there any extrapulmonary organ dysfunction like kidney, renal dysfunction, and so on.
Mhm.
And I think if you have these core informations, you can take probably the right decision. But I think all of this information are key, are very important to make the right decision for the right patients.
Great. There's a question here. Is there a limit of BMI for ECMO cannulation?
I would say no, based on, in our
Yeah.
understanding of ECMO over the last, 15 years. I think we've seen sort of that envelope be pushed to different degrees. And I think that, the greatest evidence out there suggests that people who are obese, even morbid obesity, super morbid obesity, very high, BMIs can do quite well on ECMO. In fact, they may have, similar to even slightly improved mortality compared to those with the same degree of lung injury with normal BMI. One could imagine that some of that hypoxemia that they might be experiencing might be due to atelectatic lung in the setting of high BMI. And so maybe that, those patients actually have less severe lung injury than some non-obese patients, with similar gas exchange impairment.
What's the largest BMI that you have had patient
81.
cannulated?
81.
Oh, but you beat me. I saw 67, but 81, wow. That's amazing. Do you like ventilate these patients differently? Do you are like you more prone to use like esophageal balloons or other techniques to have appropriate ventilation in this population, overweight patients and obese patients?
Yeah, yes, in my department, specifically for this subpopulation, even if we don't have obese, so many obese patients like in US, but we are prone to use esophageal pressure to monitor the respiratory mechanics, because paying only attention to the ventilator waveform and the information that you get on the ventilator are probably not enough in that subpopulation. So in this specific population, we almost always try to use, especially for very large BMI, use esophageal pressure to monitor the respiratory mechanics, to set the adequate PEEP, because PEEP, having the right PEEP in this subpopulation is challenging, but it's quite important. And this population, we frequently use prone before, but also during ECMO, because they are usually good responders.
Great. I think Matthew already almost told me this, but like, how do you ventilate your patients once you put them on ECMO?
For me, we use something which is not well defined, which is called, but it's a global entity, which is called ultra lung protective ventilation. So the idea is really to rest the lungs. So by doing, at least by decreasing most of the respiratory settings, the respiratory rate, the tidal volume, the driving, trying to target a driving pressure lower than 14. This is well demonstrated now, but what we don't know yet and what we don't know now is how far should we go? Because technically it's feasible to go until reaching an apneic ventilation, for example. Is it useful for the patient? This is another question that is not answered yet. But for now, what has been shown in the EOLIA trial, in the CESAR trial as well, is that when you start ECMO, you need to play with the ventilator. Otherwise, it's probably useless. You are still aggressing the lungs. So you have to ventilate the lungs gently and by decreasing the tidal volume, respiratory rate, and driving pressure, and also FiO2 as much as you can.
I think maybe just to mention that it's still, we follow a very similar procedure, as Mathieu said, in the absence of any other specific evidence about how to ventilate patients outside of the clinical trials that looked at ECMO. But this is an active area of ongoing research, and Mathieu's leading a trial to help us to better understand this. Mathieu, correct me if I'm wrong, called Calm Down. There's also a large UK trial called Romeo that's also examining this question. So the good news is that hopefully in the next few years we'll have some more data about what might be the more appropriate way to ventilate patients during ECMO. But in the interim, at least here in Toronto, we use a very similar approach to what Mathieu described.
Same here.
Great. So there are a couple of questions. One says, and I think this can be a little bit connected, is like, will there come a day when ECMO is initiated before mechanical ventilation? And then the other question, also kind of in a similar way, is like, which patient do you extubate before decannulation?
And I think we may, I guess for the extubation question, which, we tend, at least honestly, the pre-COVID era, we probably extubated about 20 to 25% of our ARDS patients on ECMO. I think COVID sort of changed that a bit for us. But the patients that we consider extubation on ECMO are really those who have like demonstrated that they're doing quite well, right, on the circuit. They have no complications of ECMO. They have no hemolysis or bleeding or other things that might make us inclined to remove ECMO first. They have room to go on blood flow and sweep gas flow. So when and if we extubate, we have a little bit of a buffer, and they don't have any other physiologic comorbidity that may limit our success in that manner. So they're not in severe septic shock. They're not in multi-organ failure. They can be awake in a non-delirious way, interactive following commands, and we don't have any fear they'll be pulling at the cannulas or those sort of things. So the patient really has to sort of pass that high bar to allow us to consider that. But I can say that in the patients that we have extubated, those that have met sort of this loose criteria, this approach, we've usually had them do quite well. The vast majority of them don't need to be reintubated, and then they can ultimately come off ECMO while on high flow or some nasal cannula or whatever it is, when the time comes.
Yeah, I agree with Cara. I think extubating on ECMO is probably easier than cannulating without being intubated. And I think we are still far from being able to cannulate patient without being intubated. So maybe in the future we will see it. Maybe the paradigm will change. But what has been shown so far that it's feasible. It will concern very few patients. And what has been shown so far, even if it's retrospective data and monocentric data, is that for those patients who fail, meaning those who need intubation at some time during the ECMO run, they have a worse prognosis compared to those who have never been intubated. So it means that you need really to pick the right patient to do that innovative procedure approach. which is not well defined now, and we don't know exactly who might likely benefit of this strategy.
I think the last thing to add maybe to that, both the ECMO before intubation or extubation on ECMO, is to remember that the other important function of intubation is airway protection. And, so a lot of very sick patients that you might get called to the emergency department or that sort of thing, that, again, just thinking about a patient in septic shock here, I mentioned multi-organ failure and is very hypoxemic or hypercapnic with ARDS, they often also are maybe a bit obtunded or have altered level of consciousness. So again, the idea that we could fix the gas exchange by deploying ECMO early for sure, but again, they might have other indications for intubation. And similarly in the extubation story, one of some data that we have that we can extrapolate from looking at studies of CO2 removal and COPD exacerbations, one of the main reasons that a good number of those patients required reintubation, even when we use CO2 to prevent intubation because they were on non-invasive ventilation, or you facilitated early extubation in patients who were extubated, like many of them couldn't manage their secretions. Now, again, as we think about some of these patients, they're probably a bit older, a bit more frail and that sort of thing, and weak. And so that might be part of the story there. But just to recall that at least the data that we have in some of these situations, like some proportion of patients weren't able to manage secretions and this sort of thing and needed reintubation for that, from that point of view. And also similarly thinking about the time when it comes that we might think about instituting ECMO without intubation, that there could still be some patients who will require it briefly because of airway protection issues.
Yes, and I will add, this is some of the patients that we are going to see in the OR that are going for specific procedures when you have very high risk with intrathoracic masses, airway obstruction, etc., that you are going to do cannulations percutaneously without even sedation sometimes, but it's for like something that you are going to solve. And that actually opens up my first case, because we have been chatting a lot and we have a lot of questions from everyone. But I had this case and I thought it was a good case to ask. So we had a 25-year-old pregnant lady. She has a neck terminal cancer for what she has no exit strategy, and she's not a candidate for radiotherapy or chemotherapy or surgery. And despite that, she decided to become pregnant. And so now we are called by some colleagues because she is intubated with a very small tube. That was the only thing that they were able to pass. And she is 26 weeks of gestational age. And they're asking if we would use the ECMO, not as an exit strategy for her, but as to target fetal maturation. And this case, it was very open, and we never ended up having to make the decision if the patient will or will not go on ECMO. But I thought it was a very interesting case to open up because it brings up a lot of the things that we say are contraindications, but it also opens up a very, contemporary topic and things that we are going to be called for. So what do you think? And I think it's very different in every country. Like here in Costa Rica, all the fetus have rights. It's not the same in other constitutions. So it's a very tough case, but I thought I will ask, what are your thoughts about that?
I agree that it's a very tough case. I haven't experienced such situation. However, what we can say is that technically it could be a way to pursue the pregnancy until reaching a term where it could be safe to extract the baby. Is it technically feasible? I think so, and we have seen pregnant women giving birth on ECMO. And then you have all the ethical discussion, which may vary from one country to another. It should be something which should be very clear with the team, the parents, and all the stakeholders. I don't know. I don't know if this situation happened. I don't know exactly how we can handle this in France. But yeah, technically it's feasible, and but I think the management may vary from one country to another and from even one team to another.
Right. Concerning some of the questions that they've also put in the chat, what if you are called for a patient that has been ventilated over 14 days? Would you consider this patient a candidate? What would you ask, or what will your concerns be for a patient that has been ventilated for a while?
We certainly have taken patients who have been ventilated for longer durations, upwards of 2 weeks. I think the longest I can remember actually was 23 days of intubation prior to ECMO. Some of the considerations, and these cases have been few and far between, but the patients that we have placed on ECMO after this extended duration have usually been young, single organ failure, and often they were intubated for an initial insult, maybe a pneumonia, or a couple I can think of actually had traumatic ARDS. They then, recovered, were on lower vent settings, so not 100% FiO2, really appropriate ventilator pressures for some duration of time, and got a second hit. So maybe they developed a VAP or something and had a secondary worsening. I think in the patients that we have considered at that point, those have usually been their characteristics, and they have actually all done quite well. But we're quite highly selective in initiating ECMO.
Yeah, no, I was just going to say I agree. I think trauma is a great example where a young person typically undergoes a trauma. The lung isn't actually the thing that got injured in the initial sort of situation, but then subsequently, because of the trauma, they're in the ICU for a while, they're ventilated for a while, they develop a serious ventilator-associated pneumonia or sepsis, down the course. So I think in that situation, exactly as Kara mentioned, we've definitely put patients onto ECMO in that scenario. And I think maybe just in general, I think again, absent clear evidence, it is a bit unusual to have a very sharp or arbitrary cutoff for ECMO consideration, right? I think you really want to take a case-by-case indication and think about the patient rather than like thinking that again, whether it's 7 days, 10 days, or 14 days, that somehow at 13 and a half days, the patient's a great candidate if they're single organ failure, young, and you think they have a reversible cause of ARDS, but suddenly at 14 and a half days with the same scenario, they're no longer candidates, right? So I think really that maybe the idea is to avoid the idea that there's some hard and fast magical threshold, but to consider all things on a case-by-case basis and understanding for sure the longer people are ventilated, the higher the risk of ventilator-induced lung injury and maybe irreversibility of the underlying condition, but you want to consider that on a case-by-case basis and not use a single number to decide alone.
I do
And they
agree with
actually,
Lady and Kara. I think we could not deny ECMO just based on the mechanical ventilation duration. It should be a case-by-case discussion, weight with other parameters, age, renal insufficiency, if the patient is already on dialysis, and so on. And sometimes what we ask when we are facing to this kind of situation, when the patient is ventilated for a prolonged period of time, we ask for a CT. And having a thoracic CT could tell you what is the damage of the lungs. Is there any already fibrosis pattern image that may indicate that you are possibly treating irreversible lesions, or on the other hand, if you have no fibrosis lesions, we will probably cannulate the patient, even if the patient is cannulated for 15 or even longer time.
in the same page, they're asking if you will consider the time that the patient was on non-invasive ventilation before endotracheal intubation.
I think this is something that we have learned during COVID-19 pandemic. Clearly, before the pandemic, because before COVID-19, we didn't pay attention, at least in my department, we didn't pay attention much to what happened before being intubated. And when we have seen what we have seen during the pandemic, especially during the second, third, and fourth wave, when the patient used non-invasive oxygenation strategy for a long period of time, we have seen patients who are intubated after, let's say, 10 days on high flow nasal oxygen or NIV, and who have a dramatic respiratory mechanics. And in that case, I think even if the patient is only ventilated for 1 day, so you can guess that it could be a good candidate because he's not invasively ventilated for a long time. But in fact, the 10 days of non-invasive oxygenation strategy clearly impact the final prognosis of those patients. So this is why in that case, we pay attention to what happened before being intubated. We frequently ask the referral team what is the compliance at day one of intubation. If the compliance is already extremely low, it means probably that the respiratory mechanics is already very impacted by the long period of time with non-invasive oxygenation strategies.
There was a question about what about hypercapnic patients which do not meet ARDS criteria or clinical features of ARDS, but when do you put them on ECMO?
The most common patient we see in that scenario are those with status asthmaticus, those who have severe hypercapnic acidosis, from an asthma exacerbation, and our, I think, initiation criteria is variable, frankly, because there's not a lot of evidence as to when, to initiate ECMO. We certainly will ask the hospital, usually it's a referring hospital or, on occasion our own teams here, to really try to optimize the ventilator first as much as possible. Initially make sure they're getting steroids and nebulizers and whatnot. But if that patient remains quite sick, and what does that mean? Maybe, I don't know, usually it's about a pH for us of somewhere 7.1, 7.15, maybe less than 7.2 if they also had signs of barotrauma or hemodynamic instability or, bursting dynamic hyperinflation, that we would probably consider it. But it is, I think, very patient dependent, given our lack of robust criteria and the dramatically different trajectories patients with asthma, for example, can take. Sometimes people will break quite quickly and they can be extremely sick, yet improve nearly as rapidly, and that ECMO might not be the best thing. But if they're really demonstrating, persistent, severe, or life-threatening hypercapnic acidosis, we would try to initiate it as soon as possible.
Great. And then there's another question that say, when would you use venopulmonary artery ECMO versus VV ECMO, either for ARDS or as a bridge for a lung transplant?
Well, I mean, at least in our center, we're not using this route of cannulation routinely, although it is available. We tried using it a few times in COVID-19 at, I would say, very relatively small experience and mixed results. Again, maybe not so much related to the cannula, maybe the patients that we deployed it on. But certainly from a theoretical point of view, it seems that, deploying this kind of cannula in a patient who has concomitant RV dysfunction might be the population that you want to consider it, given its potential or putative RV protective effects because of where the drainage occurs. And at least there's some observational data that suggests that might be the case and some systematic reviews of observational studies that suggest that. But again, there's no rigorous data to help us understand which patients are the best for this kind of cannula. But again, based on the cannula's properties, you might consider it in patients who have serious concomitant RV dysfunction. And we also have used it in bridge to lung transplant patients for a similar reason, for all the benefits, not necessarily of venopulmonary, but the fact that it's a single site upper body cannulation might assist or facilitate mobility in those patients and that sort of thing. But it certainly is an open question that I know there are investigators around the United States and probably the world that are investigating the specific route for those to help answer some of the questions that you're asking. I'm not sure if Kara or Matthew have any different experience or observations about this cannula.
At least in my department, like KD, we have a small experience. We have used that cannula a couple of times, especially during COVID-19, but not as a primary regimen, not as a primary strategy. We use it when after a couple of days or even weeks, we show that the patient has a very severe RV dysfunction refractory to inotropes. Then we switch to this venopulmonary artery cannula. Maybe a subpopulation when it could be useful is patient with sickle cell disease. It's a lot. There are lots of patients with this disease in France. When you have usually a pulmonary hypertension, RV dysfunction, and you have an acute chest syndrome. So in that subpopulation, it may be a niche to use this technique as a first strategy. But again, with a very limited evidence.
And our experience is similar. Ours quite similar to Eddie's. It's not something we've used routinely in our ARDS patients. So we just very limited experience.
From all the contraindications, immunosuppressed patients was one of the initial. Which are the contraindications to cannulate patients?
I think the main one is irreversible lung lesion if the patient is not a lung transplant candidate. I think this is the main contraindication. Immunocompromised, immunosuppression are not a contraindication anymore. Obviously, it's a case-by-case discussion. Not all immunocompromised patients should be candidate for ECMO, but it represents, in the EOLIA trial, just to give you an idea, it represents 25% of the population included. So I think we cannot exclude that subpopulation. But clearly, irreversibility of lung lesions without any clear project, if the patient is not already listed or is not already a candidate for lung transplant, for me, this is the main contraindication for VV ECMO.
I agree. That's really the main contraindication is the non-transplant candidate patient with irreversible lung injury.
I think
What
maybe
about-
the other one that you might consider is if something, again, the trauma example might be a good one, as if there's something that's happening with the patient that is more prognostic than the respiratory failure, right?
Yes.
So if they have other organ dysfunction, and unfortunately the patient, say, has severe neurotrauma, just as an example, is going to die or not recover because of neurotrauma, fixing their ARDS or their their hypoxemia is probably not going to be a big victory for the patient if they're going to die from some other cause. So again, like maybe end-stage metastatic cancer.
Yeah.
Again, not all cases, but that might, if they have days or weeks to live and they have a serious infection, you might question whether solving the ARDS component of things would be useful. But agree, the main contraindication would be irreversible lung injury without an exit strategy available.
Do you have experience cannulating patients with oncological disease, not necessarily primarily in the lung, as a temporary measure while they receive chemotherapy or other strategies?
Yes, the cannulation is not always VV in that case, in my experience. For bulky lymphoma, when you have compression of the pulmonary artery, we have a couple of cases when the patient was cannulated on VA to support the RVE and to support the heart function, more than the lung function, in fact. Doing chemo on ECMO, and then seeing that the tumoral mass was progressively decreasing, and you have a relief of the compression of the pulmonary artery, leading to the possibility to win via ECMO. So yes, we have done that. We have done that also for hematological malignancy, when you have lung involvement. Is when the diagnosis is just done at that time. In that case, it could be a good indication for support to support the patient on VV. Obviously, if he is refractory to any other procedure, because it's always challenging to put VV ECMO in a patient who will get hemostasis disorder with a chemo and low platelet count and so on. So if we can avoid using ECMO in this context, it's always better. But if you have no choice, it could be a possibility with some successful cases in the last years.
How often do you have to run ECMO without anticoagulation? There's also a question about which anticoagulant do you normally use and what is your protocol, but is it also common that you run it without anticoagulation?
We're pretty, I think, liberal about stopping anticoagulation in patients who have any bleeding complication or thrombocytopenia. And in our VV patients, we really don't think too much about it, frankly, because we've seen, very good outcomes, very few occurrences of circuit clotting where it needs to be changed, the ECMO circuit needs to be changed, and people can do quite well. In fact, we'll place patients on ECMO for severe hemorrhage, right? Someone with severe DAH or maybe massive postpartum hemorrhage. And, really don't worry too much, about that element, and manage them off heparin. Even in our VA patients, most commonly for us, this is our bridge to transplant population. If they have a bleeding complication, we will still stop the heparin. Much more cautiously, certainly in a VA patient than a VV patient, but could have good outcomes in both.
Yeah, I think there's a growing experience, especially in VV, like at least single institution publications suggesting like no anticoagulation when there's sufficient extracorporeal blood flow could be used, and they're just providing DVT prophylaxis as they normally would to these patients who are critically ill in the ICU. And at least there's a few trials now we're participating with Vanderbilt looking at a strategy of no anticoagulation in these patients. So really to reduce hopefully the complications that might be associated with both the coagulopathy and subsequent systemic anticoagulation. But certainly in the VV setting, it seems like there's a growing experience that suggests very low intensity anticoagulation or perhaps no anticoagulation alone may be feasible in these kinds of patients.
Yeah, I do agree with Kara and Eddie. I think we have to be relaxed with anticoagulation on VV ECMO, and we have really to distinguish VA and VV. I mean, the risk of thrombosis is extremely different between these two populations. So on VV, you are running it with higher flow. The heart normally works pretty well, so the risk of thrombosis is much lower. So we use very low anticoagulation. We are not afraid to stop it if needed. If you have any bleeding or any kind of even risk of bleeding, we will stop anticoagulant easily.
I think
Great.
maybe just to
And
comment, sorry, Deanna, on the second part of the question, I
Go
guess,
ahead.
yeah. So like a lot of interest in using alternatives to heparin. So at least in the most recent ELSO-based surveys of global practice, heparin is still the number one anticoagulant used, no matter what your target is. But certainly a lot of interest in recent years for the question in the chat about using other agents like direct thrombin inhibitors like bivalirudin or argatroban. These are the things that, again, like I think this is a question dying for an answer. Hopefully in a trial, at least in pediatrics, they seem to be a bit ahead of us. There's been recently an RCT of bivalirudin completed, and the sum total of the evidence in the pediatric world sort of suggests that bivalirudin might be better. Seems like less transfusions, less bleeding, less take back to the OR. So some of these outcomes seem to be improved with the use of bivalirudin over unfractionated heparin. But again, at least in the adult world, I think it's unclear at the moment whether direct thrombin inhibitors, again, theoretical benefits, but we don't have any rigorous data at the moment to suggest the routine use of direct thrombin inhibitors over unfractionated heparin. And again, especially thinking to the last question, which is if we sort of determine for VV ECMO routinely you don't need any anticoagulation at all, then the best choice will be just DVT prophylaxis. But certainly if for those who require it, then it's an open question that needs an answer at the moment.
And if I can add one point, I think there is also 2 points that you have to consider when we are talking about alternative to heparin is the cost, because heparin is almost free. But beyond the cost, I think is a lack of antidote. And when you are facing a bleeding event, you are sometimes very happy to have an antidote. And this is probably one of the main caveats of this alternative to heparin.
Yeah, and the pharmacology in me also tells me like your half-life of the medication, because it's so easy. You stop heparin, 2 to 4 hours after you have nothing. But then medications with longer half-life, that can also be trapped in the membrane. That may be something to consider on. We're waiting to hear about the results of these trials without anticoagulation. There's a question about a patient who has like persistent air leak. When do you say it's time to stop ECMO support? I will also tweak it a little bit of how do you know, or when do you know that we are in a course of futility and we should be stopping these long ECMO runs, and when do you decide to stop? How do you manage in your own settings? Because of course, this is very dependent on like laws and cultural and spiritual practices everywhere.
So I am not able to give you a formal recipe, when should we stop VV ECMO, because what we have learned so far is that the lungs are an extraordinary organs, but it may take lots of time to recover. And we have seen successful improvement after 2 months, 3 months, especially during COVID-19. No one from the team thought that those patients will get through this situation, and 1 year later they came to wave us in the department. So I think we have learned humility, and it's extremely difficult to predict by how much the lungs can recover. So in my department, we have a general approach is to say that as soon as you have single lung impairment, we still continue. And I don't know if it's a good idea, if it's a good thing, but clearly it lets the chance to the patient to have a late recovery, and we have seen late recovery.
I totally agree with Mathieu in that it's so humbling actually to know that if we support that patient long enough, allowing for that injury to heal, that they can do quite well. And I think that's really remarkable. And as ECMO has become safer and more complication-free, and we can support patients for longer, we've really been able to kind of push that duration of how long is too long, or how much time has been given, further and further down the road. And so I think as long as that patient's not in progressive multi-organ failure or has another complication in that really is going to prohibit or limit their recovery, it's reasonable to, obviously you can't, like Mitsu said, there's no real one recipe, but it's reasonable to keep considering and continuing to support them.
Yeah, I think we even see it here in Costa Rica during the pandemic. We had patients that were on ECMO for months and walk outside the hospital, and that's something good to see. Unfortunately, not every long case gets to that, but at least if the patient has a chance, I will still think it's feasible. Eddie, you were going to say something.
No, just that I agree.
After your patient has been for a while supported on VV ECMO, and we know some of them tend to like have right ventricular dysfunction, is there a point in time where you think about switching to venopulmonary ECMO, or adding a right side impella, or even an arterial limb?
As I said, we have switched to venopulmonary cannula a couple of times, but only for patients when it was not manageable with a little bit of inotropes. It's always challenging to change the configuration. I have no experience with right impella. I don't think it's available in France yet. But it's it concerns very, very few patients, in fact.
Yeah.
And outside the COVID cases, I don't remember any patient who are not COVID who got this issue with a late RV dysfunction after a few weeks on ECMO.
Our approach would be similar in that we would probably, for someone with progressive RV dysfunction, try a little bit of inotropy. If that failed, consideration of VAV conversion or a VPA.
Okay, I have two more questions to finish, unless like someone from the audience gives me a better question. Mine is like, how do you wean your patient? Like, when do you decide your patient is ready to be weaned, and how do you do it? Because I know everyone has a little bit of differences in practices here.
So maybe I'll go to give a plug for so we have an amazing colleague, Deanna knows here in Toronto, who's spent most of his graduate work on liberation from VV ECMO, Ricardo Figueroa Paredes. And so anyways, like I think the idea was to use the analogy, at least in our center, of all the work that's been done over the previous decades on liberation from mechanical ventilation, that having a protocolized approach led to benefits in duration of mechanical ventilation, ICU length of stay, and mortality. And so we're hoping that very similar effects could happen for ECMO if we take a very standardized approach. And so Ricardo and one of our colleagues from Vanderbilt, Whitney Gannon, are just on the verge of completing a randomized trial. I think we have 8 patients left to randomize. We're at 312-ish patients using this kind of approach where you have a very similar readiness or safety screen to make sure the patient, all the usual things like you think about in ARDS. There's been improvement radiologically, clinically, there's reasonable compliance, they're on moderate ventilator settings, and this sort of thing. And then you can have a trial, presuming you pass a safety screen, the patient could have a sweep off trial to see if they can come off ECMO. At least in our center at the end of COVID, Ricardo implemented this on an observational basis, and 25% of patients from us who had a sweep gas off trial from 4 liters of sweep gas never went back on and were ready for decannulation. That was a bit of a surprise. And then, as I said, this sort of was the fuel. Whitney had done something similar in Vanderbilt, and we're now in this multi-center trial across North America, nearly ready to have the results. So we'll hopefully be able to share something about this approach. I think Cara Center is also participating. So, but that's the approach that we're taking now in our center.
Great. So I don't see any other pressing questions from anyone. So this is my closing question. If you could give 2 advice, one, it will be how to choose or to optimize patients, and the other one, once we got them on ECMO, how to manage them to improve our patients' outcomes. What do you think those recommendations would be?
So I will not be very original, but I will say try prompt positioning before ECMO consideration. I think it's extremely important, and we frequently want to skip that part, but clearly lots of patients will go successfully through without ECMO, just with prompt positioning. So we have to keep that in mind. And the second point on ECMO for the management, I will say try to not to over sedated those patients. It's not because it's a very sick patient that he has to be deeply sedated. And promoting spontaneous breathing, active rehabilitation may be beneficial at some point, probably not early on. We have to accept that during the first days or even the first week, the patient has to be deeply sedated to perfectly rest the lung. But at some point, you need to switch and change the way to process and to have a proactive strategy to try to awake them and to start rehabilitation, even if it's not early rehabilitation anymore, but to promote rehabilitation to make the case successful.
Great.
Maybe I'll go next. Maybe I'll give one piece of advice that sort of sums it up. I think that from my point of view, what I've learned from taking care of ECMO patients is to remember that we're caring for the patient and not the device. I think a lot of times these patients, like just as Mathieu just mentioned, like there's nothing I would say super special about an ECMO patient. Remember, underneath the VV ECMO or the VA ECMO is a patient with ARDS or a patient with cardiogenic shock, just an example. And so we're treating ARDS patient and we're treating cardiogenic shock patient. We're not treating ECMO. And sometimes the focus seems to drift from treating the patient to treating the device. It's chattering, it's alarming, it's not working optimally, this sort of thing. And some of the things that we do to solve those problems are at cross purposes to how we would normally treat a patient with ARDS or cardiogenic shock. So I often like to remind the residents or sometimes the nurses when they ask questions is that just remember that, we want to focus on treating the patient and not the device. 20 years ago, we attached patients with these problems to different devices, high frequency oscillation, balloon pumps, all these sorts of things. 20 years from now, we'll attach these patients to different devices, but there'll still be a patient with ARDS and there'll still be a patient with cardiogenic shock, and we shouldn't forget to focus our treatment on the underlying problem and on the patient.
I totally agree with both Eddie and Mathieu. And I think that our goal in ECMO is not physiologic perfection, it's physiologic adequacy. We want to support them in an adequate way to allow us to minimize these other harms that, complications that naturally come with critical illness and ICU care, and even in non-ECMO patients like sedation, et cetera. And then I think really is sort of, as we touched on earlier, that the lungs have a remarkable ability to heal over time. And resolution of that lung injury, attenuating that lung injury, not only during the early ECMO course, but as time goes on, with fluid management, protective ventilation in different ways, is really important, and letting that patient have the time they need to recover.
Great. I want to thank to all the attendees for joining us and all the experts for giving us their time and their expertise. And don't forget, we're going to have ELSO LATAM this year in November in Costa Rica. And all these experts are going to be here with us. So imagine the conference that we're going to have. And I hope to see everyone joining us this year. Thank you so much for your time, everyone. It's so good to see you all.